Good afternoon. With that, we move on to every intensivist bread and butter, sepsis. We have an expert panel discussion on the evergreen topic, investigational therapies in sepsis, and we have various speakers and moderators who have flown in from different parts of the country for this. I'd like to call upon the moderator for this session, Chairman and Senior Consultant Critical Care from Gangaram Hospital, who is a Padma Bhushan winner, Dr. B.K. Rao. A warm welcome to you, sir. He's one of the doyens of critical care. Welcome, sir. I'd like to call upon the panelist, Dr. Tejas, Senior Consultant Intensivist and Director, Gokul Hospital, Rajkot. Warm welcome to you, sir. Dr. Tejas. We next have Dr. Srinivas Samavedan, Head of Department, Critical Care Medicine and Director, Virinchi Hospital, Hyderabad. Welcome, sir. I next call upon Dr. Ashit V. Hegde, Consultant Physician and Intensivist, Head of Critical Care, Hinduja Hospitals, Mumbai. A very warm welcome to each one of you. The floor is all yours. I'm sorry. We have two more panelists, Dr. Suresh Ramasubban, Senior Consultant, Pulmonary and Critical Care Medicine, Apollo Multispecialty Hospital, Kolkata, Dr. Himanshu Devan, Associate Director and Head Critical Care from Faridabad. Welcome, sir. And the dais is yours.
So we start with thanks to the organizing committee for giving us all a chance to talk about such an important topic. By now, we all know what sepsis is and what is the importance of sepsis in the critical care. There are certain things which by now everybody agrees, and there is a consensus, one, that it has very high mortality that has to come down. Part of it has come down because of the surviving sepsis guidelines. But these guidelines primarily address the evidence-based best practices. And we all know the problems that we have in the lower and middle income countries following some of these guidelines, and also that whatever they have recommended against or suggested against, they are still, some of those things are still in clinical practice. There have been a number of trials for the last 4 or 5 decades, trying to find out a drug which specifically can control sepsis or prevent its progression from sepsis to organ failure, because we know that the majority of the mortality is when you have multi-organ dysfunction. The trials that have taken place, we can't cover all of them given the time constraint that we have. So we'll divide them into 3 categories. One where there are promising results, but they are still in the preclinical trials stage. Secondly, the trials which have made it to the human trials, but the results of the trials are not in agreement, and there is a scope that we can maybe get a better answer if we were to do larger trials in future. And the third one is where the preclinical trials made it to the human trials, and the substances were found ineffective. So what we will do is we will try and focus on the trials that have, some potential, that have been tried well. There is lack of consensus as far as the results are concerned. And you will all agree that there is nothing else in the ICU where we have not found a drug, even after looking for it for the last 50 years. So the question is, where is the problem? Is it the trials where the problem is there, or is it the disease where the problem is there? So the challenges that we face while we are doing research on sepsis, that is the first point. Why have we not been able to find a drug in the last 50 years addressing the specific target of sepsis? So I'll request the experts to tell us why we have so far not succeeded in finding a cure or a drug specifically for sepsis.
So, good afternoon. Welcome, welcome back for this panel discussion. So, the question now is, why are we not able to find a magic bullet for sepsis? The simple answer is sepsis is not a unidirectional phenomenon. It's a syndrome, and it's a syndrome which encompasses multiple collaterals which boil down or zero down onto cellular dysfunction or dysregulation that is mediated by the immune system. What exactly deranges this immune system? I think we have very poorly understood it since for the last 130 years that we have been dealing with sepsis. Only now we have just begun to realize that it is not just the effect of a microbe on the body that causes this immune dysregulation, but the dysbiosis in the host's own gastrointestinal flora that can trigger the cascade of events that mark the pathophysiological manifestations of sepsis. So, as long as we don't identify what is the putative mediator, we may not be able to hit the target, and that's probably, in my opinion, the reason why we have projected a lot of magic bullets, some inexpensive, some very expensive, all of which have failed and failed spectacularly.
No, my thinking as to why most of the sepsis trials have failed is because the population that was studied is very heterogeneous. I mean, any therapy, with the population that suffers is a sort of heterogeneous population. A particular therapy which might be useful in a particular subset of people might be harmful to the other subset. And if you include everybody in one trial, like say low PEEP or high PEEP or steroids and those, everything, so high PEEP does good in some people, does bad in some other people. So unless you identify a priori which is the subset of people in whom that therapy is likely to work, if you just lump everybody into one trial, it's unlikely they're ever going to get a positive trial. I think that's the main problem why sepsis trials fail. We know that people who are pro-inflammatory, people who are anti-inflammatory, and you put one particular drug, it's unlikely that in a randomized trial with a heterogeneous population, you'll ever get a positive result. That's why I think most sepsis trials have failed.
I agree. I think sepsis, as rightly said, like AKI in the previous discussion, it's a syndrome. So again, if you don't know which itis, and every itis might have a different, a pneumonitis, a biliary sepsis may have a different way in which we react. And classically, if you remember from the Zygris days, you had this photo of a three-headed sepsis is a three-headed monster with coagulation, inflammation, and the problem of this thing together, and we were targeting selectively one or two or three of them, and then invariably you're never, and you're looking down at the cascade, and we are forgetting at a lot of patients who actually have a hypoimmune response. So we are not looking at sepsis only as a hyperimmune response. So there's a huge subset. So it has to be personalized, and that's where the idea is, because if you look at genomics in sepsis, you will see that not everybody falls into the same category. So that's why things are not working, is what I agree with Asid and Srinivasan.
So we have 30 years of research failed in sepsis. So it's good 30 years we've not been able to get anything substantial. That's a game changer. We have tried a lot of things which have come, they have gone, they've been tested. And I have my take on two big reasons that this has happened. One is that a lot of time the preclinical animal data we are unable to translate into human data. One, I'll tell you why. And the second is that we're trying to fit, as previously said, one shoe fits all. It doesn't work that way. So we have to individualize our drug therapy. We have to go from a stratified medicine, drugs based on a certain score or certain biomarker, to more of genomic based precision medicine, where we know the genomic potential of the organism, of the person, and the pharmacogenetic potential of the drug that is required to make those drugs more targeted and the trials more successful. Coming to my first part, where we had animal models, the basic physiology of murine models is very different from animal models. Everything, their basic hemodynamics, they're tachycardic, they are hypothermic, their immune system is lymphocytic dominant, we are neutrophilic dominant. Across the board, our biomarkers are not the same. So how did we choose to translate that murine model into human trials has become a big challenge. That is why we fail in 30 years to get anything substantial.
And why we are failing in trial? Because we are not getting enough number of patients for randomized controlled trial. Moreover, the investigational therapies are also, some therapies are costly. So in country like India, we not getting enough number of patients, and etiology of each and every patient is different in patient of sepsis. So we have no enough data collection for outcomes. Some trials hang in betweens. Like
So what we've said is that there is heterogeneity when it comes to the phenotypes that we are trying to address in those trials. So maybe the subjects are different, maybe the methodology is different. We don't know when to start, how much to give. And of course, patients come from different presentations, different background, different comorbidities. So all that is understood. And that is probably one reason why we have not yet put our finger on what is right. But let's look at Zygris or activated protein C. I mean, that was a blip. It was there. We had hopes. It flopped. But since it flopped in 2011 and it was withdrawn, nothing much has really come up between these 11 years. But we can't let go of Zygris just by saying that it didn't work. There was a lesson that we learned from Zygris. And Zygris, we knew that it was the same company, the same drug, the same dosage, and yet the results were different when different trials were done by Eli Lilly. So what is it that we learned from Zygris? Because tremendous amount of money had gone down the drain for Eli Lilly, and we just can't let it go without learning lessons from it. So let me ask the experts as to what message do we get from the failure of Zygris, and does it have any implications for the future trials that we are into now?
I can go. I think Zygris, since we were in a generation which we used a lot of Zygris, so we can say we did read a lot of that at that time. I think Zygris or activated protein C focused on the immunothrombosis part of the of the sepsis model, and there was then the subsequent analysis and the other benefits were added on later rather than they were not. So those were things which were, when we were seeing a positive response, those were added on. So I think the initial objection to the use of the activated protein C actually came from PGI Chandigarh when they wrote, if you look at the number of patients who got heparin in the activated protein C group did better than the people who did not get heparin in the initial thing. So maybe heparin had the same effect. That's why they did the heparin study also. So I think the idea was that you're focusing only on one arm of the innate immunity is activated by the PAMPs, and then subsequently the inflammation and subsequently immunothrombosis. So this, I think what we learned very good from, I think one of the big lessons for sepsis research was the fact that we were able to understand this, and now we are able to apply to COVID, because now we know for any disease which is an endothelitis, there is a problem. So if your endothelial cell damage happens, so we are able to understand the pathophysiology much better. The definitions of sepsis have evolved because of Zygris. The sepsis 3 definition is a culmination of the research that went into that Zygris. So I think we've learned a lot from the activated protein C research, especially on the pathophysiology of sepsis. And once we know more, we realize that we were targeting only the downstream thing and we need to move a little upstream, or we need to focus on something else.
No, the other thing that I think we learned from the study is that actually if you look at the Pravesh shock, the control mortality in Pravesh shock was the same as the mortality in the original Pravesh study. The mortality with the drug patients who got Zygris was the same. That means over time, even control mortality had improved. That means over time, as intensive care improves, it becomes that much more difficult for a new intervention to prove that it's of any benefit, because overall intensive care is improved, so overall control mortality itself, improves. So that I think is one thing that That's why any new drug, it makes it much more difficult for that new drug to show that it makes a difference, because overall intensive care, and most of intensive care is just routine care, and most patients just get better with routine care. So for any new intervention to show an increase in benefit is going to be much more difficult nowadays.
So my understanding of why Zygris failed, or why any other future therapy, so-called therapy for sepsis will fail, is because this approach is a reactionary approach. That means we react to something that has already gone wrong, right? And when it goes wrong in multiple territories, like in the kidney, the brain, the heart, the liver, and the intestinal vascular supply, whatever, when you react to it, you are not sure of reversing it. What you need to do in sepsis, in my perspective, is to have a predictive approach. When do you expect things to go wrong and how to prevent them from going wrong? If you can identify a set of molecules, again, I'm saying it's going to be a set of molecules, it's not going to be one, because the derangement of sepsis is multi-pronged. So, if you can identify a set of molecules which can prevent this immune imbalance from setting in, that is going to be your winner for management of sepsis. Anytime, whether it's a car, whether it's your finances or sepsis, a reactionary approach will fail. A predictive approach is always likely to be successful.
So, as previously said, I am the generation who had the opportunity to treat patients with activated protein C. Activated protein C failing is a classical example of expecting too much from a drug and corporate greed. It's a deadly combination of the two. It started that activated protein C takes care of the microvascular thrombosis, and rather it takes care of the endothelial dysfunction and improves the vasopressor requirement. And I believe all of us who have used would agree that somebody who we started on activated protein C, in 24-36 hours, the vasopressor requirement used to drastically come down with or without a mortality benefit. So that was a definite positive of that drug, which wasn't highlighted. So Proves 1 to Proves shock. They were just looking at major mortality benefits, some miraculous cure. These simple things, length of stay in ICU, ventilator days, vasopressor requirement, if they had SOFA scores, they might be able to have to save the drug. I still believe that was a good drug that we lost to corporate greed and expecting too much from the drug.
We threw the baby out with the bathwater.
So throwing out the baby with the bathwater. And in fact, there are people who say that it was wrong to compare the Proves and Proves shock trials because the research methodology was different. But nonetheless, what it did tell us is that they were, trying to identify the pathways which they wanted to address with Zygris. And those pathways have not been disproved. They are very much there. But the research that is going on, as we all agree, and as that is what the experts said, we can't target one because, like cancer, we will have to have a combination targeting different therapeutic targets. And if that be so, then where is the research taking place on which therapeutic targets are being examined and analyzed in the trials that are going on? So if you can throw light on what are the potential targets, like Zygris targeted thrombosis and fibrinolysis. So the other trials that are going on, what are they kind of targeting? What therapeutic targets they have?
I think most of the activity, most of the interest now is looking at immunoglobulins is one. There are a lot of work going on immunoglobulins. Cytokine release, cytokine action, cytokine removal is one where it's going on. Oxygen free radical related mechanisms and their attenuation is another area where we are looking at a lot of work going on. The use of colony stimulating factors to actually augment or modify the bone marrow's response to an infective stimulus is something going on, of course. APC, activated protein C, has not gone off. If you look at literature, there are still people working on activated protein C, its contribution in community acquired pneumonia, severe community acquired pneumonia, UTI. They're still going on. Maybe 5 years from now, we'll come back to, with an adaptation or a modification of activated protein C. There is still work going on that.
So I think I think one is, as I said, the three heads. So one is along the inflammatory cascade, a lot of work on how to remove endotoxins and how to remove the cytokines. That's where the major emphasis is on. So when we go to any of these conferences, we hear a lot about blood purifications, about immunoglobulins to remove endotoxin. And the other things that we were looking at is immunothrombosis, and especially the production of neutrophil elastase traps, nets, and how to modify those things would probably be the way. The three main, so immunothrombosis, inflammation-induced thrombosis, and how to modulate that so that better organ perfusion happens, and to modulate the inflammatory cascades, and to prevent the pathogen-associated molecular patterns to start the innate immunity. That's where the research is, as Srinivas rightly points. So before the whole cascade is activated, so can we do anything to look at the TLR, toll-like receptors, modify those things? That's where the focus has been to modify the immune response.
So if we can see, so being trained last 20 years, you can see the sepsis research which has shifted from resuscitation antimicrobial based research, and we lost it at Arise and Promise because we can't show any more benefit because it become a part of the standard care. And everything, as rightly said, has revolved around immunomodulation. Immunomodulation may be at the level of the presenting cells, maybe at the levels of innate immunity, adaptive immunity, or the immune paralysis that happens. So every drug that we're going to discuss as an investigational therapy of sepsis revolves around these three parameters itself. The important thing common to all these drugs while they're doing research is to prevent microvascular failure. So all of this leading to microvascular failure and multi-organ dysfunction is the end target they're trying to achieve. Hence, the benefit in mortality or the days of ventilation and so on and so forth.
One more thing is the bioenergetic failure and the mitochondrial, which is called metabolic resuscitation with the vitamin C's and things like that, has also been the focus in the last few years.
And the last one, which probably will come into, which will probably come into play, use very fast, much faster than all the others, is your fecal microbiota transplant. To make it very scientific, but it is just a stool pellet. Is, if I want to make it more grotesque, but it is fecal microbiota transplant or a fecal microbiota supplementation is probably the area where a lot of exciting work is going on, because a lot of people believe that it is the dysbiosis in the gut which triggers all the immune cascade in sepsis. So if you replace the bad bugs with the good bugs, your sepsis cascade can be attenuated. So you might see something happening on that front in about 4 to 5 years from now.
Even combination of vitamin C, hydrocortisone, and thiamine is also going on. Trial is going on. And works on prostacyclin is also going on, but still we didn't get any particular results because of lack of randomized controlled trial. So on multiple focus works is going on for adjuvant therapy of sepsis, but still where we are, we don't know.
So what we are saying is that essentially sepsis is an inflammatory disease, and if that we saw, the initial research that took place was how to control the inflammation part. But very soon we realized that it is not just inflammatory, it has an immune component to that, and there is an immune paralysis which takes place. And if you remember, in 1996 or so, Bohn had coined the term CARS, and then the focus shifted on to the immune part of it. But if we look at the genesis, it is the bacteria which causes all that. And if we have to tackle the bacteria, then virulence has to be taken out. And there are approaches, there are devices which we use even now, which are meant to do that, remove the cytokines and decrease the virulence. One of them is, of course, the polymyxin B. And we all know why polymyxin, because it has a predilection for the cytokines. So what is the expert's opinion on that? Because there is some controversy on that, because surviving sepsis guidelines say that no, it doesn't work, and it is still very much in practice. At least in Japan, it is used widely.
think the death of blood purification technique was the activated protein C actually. So before, when I joined in the US in '98, blood purification technique was pretty common to do, not a very uncommon thing to be talked about in rounds as far as sepsis management is concerned. It was not a taboo topic. But I think a couple of years later, 2001, when activated protein C research got there, it lost its technique. So I think blood purification techniques has got because it's going to be removal of a lot of products, and it is non-discriminatory. It is going to remove your all kinds of molecules, cytokines, endotoxins, and everything. So it is a non-discriminatory way of looking at therapy rather than to look only at one particular anti-cytokine or a particular anti-endotoxin level. So I think in the overall picture, if you have a hyper-inflammatory response and you're early in the scene, blood purification should theoretically modulate the inflammatory response. But unfortunately, we know that none of them have ever been able to show a difference in outcomes, whether done early or late. And that's where, and the classical blood purification of whole plasma exchange has never been successful in this regards.
Regarding blood purification techniques in general, hemoadsorption, hemofiltration, a combination, plasma exchange, I personally feel are very promising areas where work can be done. The problem we are facing right now is that we are not that selective in the removal of the products that we want to be removed and that we don't want to remove. And that is the reason of failure of the present techniques. Most of the patients let the plasma, these techniques go off. We feel that whenever a patient who's sick enough to need a renal replacement therapy, and we put them on a modality like SLED or CRRT, we see some amount of cytokine removal happening as such. And we see their vasopressor requirement going down or the patient improving in their organ dysfunctions. So the part that is theoretically correct is that the removal of cytokine in a proper fashion should help. The only problem is how to replace the things that we do not want to move out have moved out. And that is where the trials are facing. See, most of the meta-analysis were biased by the predominant Japanese trials. And the moment you take out the Japanese trial data out of the meta-analysis, the analysis do not show a benefit. And that is where Euphrates trial showed that you don't have a benefit by using these techniques. But if you don't use any of these techniques, just your patient is on simple SLED and CRRT, you have certain cytokine removal and you see certain improvement in your vasopressor requirement and multi-organ dysfunction.
So you're talking of hemofiltration versus dialysis. But between hemoperfusion and let's say cytosorb and polymyxin B fibers, which one you think has more evidence, or both of them have no evidence and both of them have not been successful?
As of now, I think they both equally have no evidence. But the thing that is gaining more evidence and there are trials to show benefit are the plasma exchanges. So with the exchange trial that was done in early sepsis, first 24 hours, you do a one round of plasma exchange, they were able to show a massive decrease in vasopressor requirement. See, when we're looking at mortality, it's very difficult to show mortality benefit after our resuscitation and antimicrobials have become streamlined. So if we're looking at parameters finer, we might be able to get a benefit. And plasma exchanges have shown that in the trial. I think last year we had the trial came out, exchange trial.
I think looking at one subset where cytokine removal and endotoxin removal works well is when you have a good source control. So if you have a post-op intra-abdominal sepsis where the surgeon has done a good job, so that is the only subset where there has been some benefit. Other than that, I don't think there is no evidence in medically ill septic patients for these molecules these techniques as of now to be in real life to be used very commonly.
I think that the complex issue with the use of cytokine adsorbent columns or cytokine adsorbent systems is your reaction is to a circulating level of cytokines. You react to hypercytokinemia, whereas the damage is done by the tissue-based cytokines. So when you remove the cytokines from the blood, you are expecting a source and sink response where the tissue-based cytokines are drawn from the tissues back into the circulation and then you remove it. We are not sure how that gradient actually works. So while the cytokines which are incorporated in the tissues continue to do harm, you are removing the circulating cytokines, which means you are also removing the anti-inflammatory cytokines. Now, where is the balance? What ratio do you target? And in your cytokine adsorbent column filtrate, are you measuring the ratio of the pro versus anti-inflammatory cytokines? If you're not doing that, and you don't know at what level the source and sink system works between the tissues and the circulation, we may be actually doing more harm to the patient by removing a carte blanche all the cytokines from the circulation.
That's true. And then the cost that gets added, and we don't know when to start, what is the ideal time to start it, where it's going to work, where it's not going to work. But what about immunoglobulins, let's say? If we are talking of the immune system, then the stimulators. You need to borrow a voice.
This is what happens. You have to try therapies. You have to juggle around different molecules.
So IVIG in theory, it can work both in the anti-inflammatory and as a pro-inflammatory, drug. So that is one theoretical benefit. It can bind antitoxin. That's another benefit. So theoretically, IVIG has a role. But one single large study which used IVIG, just general IVIG, did not show any great benefit in patient with sepsis. But then there was a meta-analysis on studies with used IVIG, and there they found that especially enriched, which was enriched with IgM or IgA, those IVIG has slightly, better outcomes than in patients where you just given IVIG. But then again, they said this meta-analysis is flawed because most of the studies included were not a great level. So when they removed all the, they include only 2 high-level studies, again, there was no great benefit. But people are still looking at IVIG because they're saying if they look at that subset, which is deficient in IgM, maybe there still is a role. So maybe you need to measure, because IgM levels, the patients who have IgM deficiency, the ones in them who get IgM enriched, they probably do better. So maybe in the future we'll have a target population. At the moment, of course, it's not recommended, and surviving sepsis guidelines recommend against general use of IVIG.
Currently, do we have a IgM enriched IVIG?
Pentaglobulin is the IVIG.
That's the only one that we have. Yeah. Okay. But any subset where it works, like we said in that subset that we were saying.
IgM, the second been looked at. It's not been proven, but IgM deficient maybe.
Because in the skin infection, necrotizing skin infections, it is still recommended and used by the emergency medicine. So it could be that it has a role there. Okay, if that be so, what about the granulocyte colony stimulating factors? No, because there is evidence coming up there, because I'm talking of non-neutropenic patients, of course.
I think, as you rightly said, the discussion is investigational therapy. So
Of course, they are all.
None of these are.
None of them is in clinical use. I mean, none of them is a recommended therapy. But that's what the discussion is all about. That where are we going in the future?
Because it's supposed to be pro-inflammatory, they say generally it's for everybody, it doesn't work. But if you look at the patients who have a low HLA-DR or a low lymphopenia, maybe in them, again, it's theoretical, maybe it will work. You give it to the entire group, it doesn't work. But you look at HLA-DR levels, because HLA-DR low might indicate that these are immunosuppressed. So
but in the meta-analysis where it was ruled out that none of them
worked,
worked,
it didn't work.
The HLA-DR was not used as a biomarker. That is the criticism. That
what I meant.
have you used that, the results would have been very different. The meta-analysis report would have been very different because the studies did not use HLA-DR.
Granted, so then it didn't work. But now they're now doing studies where they are trying to
now they are using that. So maybe things will be different at this point of time. So any other particular target that you think is promising and coming up?
Any other target that you
I think anticoagulants are back. I think heparin
What
would be
about
back.
toll-like receptors? What about TREM1? What about interleukins?
So all the TLR1 antagonists, TLR2 antagonists, none of them have been studied. None of them have shown.
No, I know nothing works. At present, nothing works. But what are the targets that research is going on?
So the research right now, which is a bit promising, are a couple of areas. One of them is the use of heparin in higher dose, the HALO trial.
But that's the one which is going on right
Going on
now.
right now. They
Okay.
have completed recruitment. So what they tried to show us with the previous trial is that using heparin is safe in sepsis, because we are fearful of the fact that using heparin would cause bleeding and unwanted risk. So one thing is that in 500 U per hour it was safe, and they're trying to use in double the dose and hopefully getting some amount of microcirculatory benefit. That is one area. The second area which looks promising is, as Dr. Ramasubramanian rightly said, that all the TREM and TLR probably have gone out and they're not really that promising. But the purification techniques, if done properly, might be one area where you should look, especially in plasma exchanges. And so one thing failed. If a polymyxin B impregnated filter failed, that doesn't mean that every other category would fail. We have to be just more selective in what we're trying to filter out.
So I think we will, that with the time remaining, we will have to conclude. But the points that we brought up were that there are many targets on which we are working. Some of them don't look so promising. Some do look promising, but the one which look promising also needs to be validated in larger trials. Some of them are going on, but their results are not yet out. And we hope that some of these trials will throw up a solution for sepsis, and hopefully in future the sepsis mortality will come down. So quickly, if we have any question from anyone from the audience to any of the experts.
No, no, there is.
No, there are questions. There is no mic. No, for the others. I can
Sir,
see
so just throw some light on the sepsivac, which is. And second thing, during one presentation, I saw bacteriophages are used to combat sepsis. I didn't understand that concept. Sir, what is the role of sepsivac? Sir, not audible, sir. Yeah, it is the same. It is the same.
Are you saying about
Yes, sir.
Mycobacterium
Yes.
W
Yeah, yes, sir.
in sepsis?
Yes, sir.
I don't think we are yet in a position to say whether it will work or not. My concern about, we did not talk about several of these putative or projected molecules like thymosin and Mycobacterium W, because whatever we have heard and read about it is a subcutaneous administration, right? Yeah, subcutaneous or intradermal administration in somebody who is already vasoconstricted, hypoperfused in the peripheries. You are playing with fire. I mean, first thing, you are not going to achieve the desired effect because the absorption is erratic. You don't know in which patient is going to be absorbed and which patient it's not going to be absorbed. First point. Second, with despite all your efforts, if he improves and the circulation improves, there is a rebound absorption. That's the nature of any subcutaneously delivered drug in a septic patient. So there are early publications which have claimed some benefit in septic patients in terms of vasopressor requirement and hemodynamic stability and time to achieve map targets, but we can't, in a meeting like this, we can't predict and say this is a subset of patients in which it's going to work.
Just a comment, sir. Again, we have started believing that sepsis is a disease. And that is the reason we are...
It's a syndrome.
It's a syndrome. So the problem is this. So I think all of us have burnt our fingers with activated protein C. After that, I don't know whether these molecules will ever come to the actual...
But those burns seem to have healed, Supradeep. So we are ready with fresh hands again.
Yeah, with more industry pressure. Okay, thank you.
Thank you to the panelists. Excellent discussion, really thought-provoking. I don't have a question, but more of a comment, I have to say. I think in terms of sepsis, I think we need to look at it from a quality and safety point of view. I think we have attacked sepsis all along from an academic perspective, trying to identify that magic bullet. I think the more time we spend, 10 years down the line, we might be sitting in the same conference hall talking about as to why we don't have any therapy for sepsis. I hope I'm wrong. But the way I look at it is that we tell trainees about quality and safety, wherein quality is getting the right things done more often, and safety is getting the wrong things done less often. Okay, so we want to get them to be thinking about. I'm sure that you didn't want to talk about antibiotics because that's a separate issue in itself, but we need to be getting good at getting timely intervention to antibiotics. You keep waffling around a patient in emergency department and not giving the timely antibiotics, not getting the resource in a timely fashion, not getting fluid administration in a timely fashion, or non-compliant with sepsis bundles. I think we need to get the right things done more often. We need to have that as a key performance indicator. If a patient doesn't have it done, we need to be having some punitive action for that because sepsis skills. I think we need to start focusing on a quality and safety perspective than from an academic perspective. Thank you.
Thank you very much. And hopefully, if stem cells can throw up a solution for that, we don't know. Stem cells are coming up in a big way. So with that, I take the opportunity of thanking all my panelists here, the experts and the organizers and the audience for their patient listening. Thank you very much.